So you can see it. So thank you for this opportunity, dear faculty, for this opportunity to be there with you. I'm so glad to be part of this course, and I was asked to answer, is there still a place for ICD therapy in primary prevention in the area of new therapies for heart failure? So patients with heart failure have an increased risk of sudden cardiac death owing to malignant arrhythmias. Two randomized controlled trials testing ICD use for primary prevention of sudden cardiac death have shown that ICD reduced sudden cardiac death and improved survival in those patients. These trials are MADID-2 and SCADA-SHIFT. Therefore, both American and European guidelines recommend ICDs for primary prevention in patients with heart failure with reduced ejection fraction. But both trials enrolled patients more than 20 years ago and might not reflect the characteristics and the current management of heart failure with reduced ejection fraction. Recent advances have impacted the risk profile of patients with heart failure with reduced ejection fraction, leading to a reduction of sudden cardiac death risk over the past 2 decades. Paradigm HF trial concluded that ARNI was superior to enalapril in reducing both sudden cardiac death and death from worsening heart failure. BERA, by focusing on very long-term survival and late sudden cardiac death in resynchronization therapy patients, showed that progressive heart failure death still represent the most frequent cause of death, and in contrast of sudden cardiac death, there in yellow, represents a very low proportion of late mortality in both groups with or without ICDs. In this recent meta-analysis, Chen analyzed data from 12 clinical trials spanning of the period from 1995 through 2014. They excluded patients with ICDs, and we see that the annual rate of sudden cardiac death is decreasing in rails which terminated in 1998 from 6.5% to 3.3% in Paradigm, which terminated in 2014. So the rate of sudden death has declined by 44%. The decline in the rate of sudden death over this period paralleled the increasing use of evidence-based pharmacotherapies that are known to reduce incidence of sudden death. So what about the contemporary prophylactic ICD therapy benefit? Let's see some new data. And the Danish trial proved that ICDs in patients with non-ischemic heart failure did not provide an overall survival benefit. Cardiovascular death were equal in the two groups, but sudden cardiac death, the risk of sudden cardiac death was halved with an ICD, and the European Committee made this study the EU CRT ICD prospective trial, which was an investigator-initiated, non-randomized, open-controlled, multi-center cohort study. The randomized trial is not possible to do because it was judged unethical, and this committee aimed to assess present-day benefit from prophylactic ICD therapy. The large majority of patients in both groups received heart failure medication according to the ESC guidelines. And we can see that sudden cardiac death was considerably lower in ICD group. And the adjusted difference in survival between the ICD and the control group was 27%. The usefulness of the ICD was unevenly distributed in the overall cohort and was highly reduced in patients over 75 years old and diabetic patients. Analysis of data from the Swedish heart failure registry, which focused on the association between the use of primary prevention and ICDs and mortality in patients with heart failure. They find that only 10% of eligible patients had ICDs, and ICD use was associated with 27% reduction in all-cause mortality during the first year, and with a 29% reduction during the first year in the risk of cardiovascular death. For follow-up of 5 years, ICD use was associated with a 12% reduction in all-cause mortality, but cardiovascular death there was no significant reduction. And finally, as a take-home message, the current recommended medication of heart failure with reduced ejection fraction, including ACE inhibitors, AR blockers, ARNI, beta blockers, and MRA, and CRT use if indicated, reduce the risk of a sudden cardiac death. ICDs for primary prevention purposes, as recommended, are underused in actual real-world patients with heart failure. Primary prophylactic ICD treatment showed a 27% survival benefit in actual typical European heart failure patient, so it has still a place in primary prevention. But for our specific African economic and demographic context, studies have to be initiated to evaluate our current practice and make our own guidelines. Thank you for your attention.